All right. Good morning, everyone. I hope you had a good weekend. I hope you're having a good week so far. I think we're in week 11. I think we have like 5 more weeks left. I don't know. I've kind of lost track of time a little bit. I know what we have left in terms of course content and what we're doing. But the end of the semester is coming up pretty quickly, as I'm sure you all know, and graduation is coming up pretty quickly. And I know many of you are graduating this year, which is fantastic. And it's great that we are going to be able to have an in-person ceremony. And so hopefully many of you are planning to attend that. I know it's not ideal because you can only take 2 of your family members with you. And that's, normally we like to take our whole family and be able to celebrate this major accomplishment, but at least we get to do something this year, pending that nothing drastically changes over the next month or so before the graduation ceremony. I plan on going, depending on what it all looks like and how they allow faculty to go and stuff. So maybe I'd actually get to see some of you there in person. Not that I would recognize, well, I guess I've seen you all on camera when we've done the one-on-one office hours, but you'd probably have to come up and say, hey, especially with masks and stuff, to be able to recognize each other. That's kind of the crazy thing about all of this is I've seen most of your faces maybe once for like 5 or 10 minutes. And that's unfortunate because I really do like to get to know my students in class. Aside from that, for the semester, as I've mentioned, you have your last 2 homework assignments. Your homework 4 is already posted. It is due next weekend. Your homework 5, I'll post at the end of this week, and it'll be due at the end of the month. As always, though, those have flexible due dates or goal due dates. So as long as you submit those assignments before the end of the semester or before you submit your final project, your accumulating final experience, then you will receive full credit on those. No reason to ask for an extension or anything. And then if you haven't done so already, you do have to do 1 more office hour with me before the end of the semester. So make sure you start scheduling those, or that you attend the normal office hours that I'm logged on to every Monday and every Thursday. 90% of the time I log onto that office hour Zoom link, and I'm just kind of sitting there by myself doing other work on my computer because nobody comes. So make sure you do that in the next few weeks as well. And then as I mentioned in the email to the class on Friday, based on the responses to the quiz and the students that I've talked to, we have switched over to what I was calling the alternate final accumulating experience, which is the recording of the videos and creating the information sheets. So we will not have a traditional in-person exam, or not in-person, virtual exam, such as what we had for the midterm. And you do not have to do that other final project that I had posted details about. So I posted the details about the final accumulating experience that you have to complete for your final grade for this class. All of the details are on Coursera Courses. If you have any questions about that, please make sure you email me, reach out to me to ask your questions early. The one thing that I encourage you to do is, because you have to record videos and you have to create those short information sheets, you will not be able to complete that whole project right before it's due. So it's due on Saturday, May 15th, I believe, at the end of the day. That is the beginning of finals week. I made it due that day because that was when our final would have otherwise been, or would have otherwise started. But I encourage you to work on things early and to start developing some of your recordings, start developing your content and your information sheets early. And if you do work on them early and you want feedback, or you want to get me to give you some feedback on what you've done, I'm happy to look through things, jump on a Zoom and say, yep, that's exactly what I'm expecting, or maybe add more details on this way. So as long as you give me, a couple weeks notice, I can give you feedback along the way. If you're emailing me the day before it's due saying, I'm not sure what to do, that makes that a lot more challenging. So make sure that you're working on things early. And in addition to that, if you're working at a team of 2, make sure you email me who you're working with so that I know what to expect and how many assignments to expect at the end and so on. So just do that sometime in the next couple of weeks as well. And that is pretty much it for the class. So we're going to talk about today experimental studies, and then I'll start to introduce a little bit of our content for next week, which is what I call threats to research and how bias and other things affect the results of research studies and why we need to look out for those things. And then to wrap up the semester, we will talk about screening for disease and how do we screen for disease in our population. What do the principles of screening tests look like? So for example, when we do a COVID-19 test and you go and you get a nasal swab, how accurate is that test? How do we determine how accurate that test is? And what do the results mean? If you get a positive result, does that actually mean you're positive, or could it be a false positive? If you get a negative result, does that actually mean you're negative, or could you have gotten a false negative? And there are ways that we evaluate how good tests are at detecting both the presence of disease and the absence of disease. So we'll actually talk about that and do some calculations for evaluating screening tests and the difference between a screening test and a diagnostic test in 2 weeks. Then we'll wrap up our new content with talking about physical activity epidemiology and chronic disease epidemiology. So how do we evaluate the current state of physical activity levels in the United States and globally? And how do we, how does that relate to chronic diseases, and what do we need to do to prevent the development of chronic diseases in the United States? And then our very last week of class will just be kind of like a course wrap up and tying everything together of what we've learned throughout the semester. Because I know this semester we've learned probably mostly all new content, and the first time you've heard about a lot of these concepts, because epidemiology is kind of this unique class within the field of the Department of Kinesiology. But we'll kind of tie it all together at the end, and then I'll have some opportunity for questions about the projects and other things to wrap up the last week. So that's what to expect this next few weeks. As always, if you have any questions or concerns, or you need anything at all, never hesitate to reach out to me. I'm always happy to discuss anything for the class or beyond, and always happy to help to ensure that you will all do well in the class. And that's my goal, is that you all, if I give you all an A, awesome, I want to give you all an A, but I can only do that if you're putting in the work to do well and to get an A, and I want to help you get there. So just make sure you're reaching out as you need help or have questions. All right. Any questions before I go on to today's lecture content? Cool. All right. So today we are talking about experimental studies. So this entire last, 5 weeks or so, we've been talking about study design and what that means for the field of epidemiology, and how we conduct research to understand not only the distribution of health issues in the population, but also to determine causality and what it is that leads to different disease outcomes, with the eventual goal, and some of the things that we'll talk about in the upcoming weeks, of being able to determine what it is that leads to adverse health outcomes and then intervene on those things to prevent those adverse health outcomes from happening in the future. So as we've talked about, our goal in public health, our goal in epidemiology is really not to treat disease, but it's to understand what it is that we're exposed to and what behaviors we engage in that lead to adverse health outcomes, so that we can develop prevention and mitigation strategies to prevent those health outcomes in the future and protect the health of all people globally. And that's really the ultimate goal, is protecting the health of our communities and everyone who lives in it in an equitable way. So we've talked about both descriptive and analytic research studies, with the descriptive studies being what we first started with, those case reports, case series, ecological cross-sectional studies. And those are all really meant to develop hypotheses and describe the distribution of disease in the population. And then we've moved on last week to talking about analytic research studies. And we focused last week on observational analytic studies, which were case control and cohort studies. And cross-sectional studies can also be an observational analytic study, depending on how they're conducted. But if you remember, a case control study is a type of observational study where you start out with people who already have the disease and you compare them to similar controls, but the people that don't have the disease, and you're examining what it is that people who have a disease already were exposed to that could have potentially led to them having the disease today. But those studies face a number of limitations that prevent us from being able to determine causality. And those limitations include things like we're not able to determine temporality. And if you remember, that's timing. So we're not able to determine if those behaviors or exposures came before the disease outcome or after the disease outcome. And so that limits our ability to say that that factor led to that disease. So then we talked about cohort studies, which are the gold standard for observational epidemiologic research studies. And cohort studies are ones where we start out with people who are disease-free and we follow them forward in time. And we can follow them for a year, we can follow them for 5 years, we can follow them for 80 years. How long we follow them for depends on how much money we have, what the disease outcome that we're looking for, and a number of other factors. But the idea here is that we're able to assess their health over a period of time and examine who develops disease so we can determine incidence of disease. And based on that information that we're collecting before they develop the disease, we're able to say, okay, so the people who were smoking for 15 years before they were diagnosed with lung cancer were much more likely to be diagnosed with lung cancer than the people who weren't reporting that they were smoking. And so that tells us more about causality, that tells us more about temporality, that we're able to fully assess or better assess if those exposures came before the disease outcome. But observational studies are still limited in many ways and they're still limited in how we can determine disease causality, mostly because when we're thinking about what is leading to adverse health outcomes, there are a number of things that can affect the results of research studies in very drastic ways that we need to be able to understand and control for in our research studies. But when we're not manipulating anything in that research study, we're not able to fully control for those outside factors that we'll talk about a little bit at the end of this lecture and next week that can affect the results of research studies in whole. So that leads us to talking about experimental studies. And there are a lot of different types of experimental studies. What we'll focus on, especially because it's what we use most often to determine causality, are randomized controlled trials or clinical trials, which most of you are probably familiar with and have heard about, maybe even have participated in a clinical trial in the past. And we've definitely had clinical trials at the forefront of our media and public health action over this last year as we've gone through the vaccine trials. So we'll talk about how we conduct a randomized clinical trial and why the process of going through the different steps of a controlled trial are important for us to determine disease causality, but more than that, to determine safety and efficacy of what it is that we're testing. And so experimental research, as opposed to observational research, which is what we've talked about this last 5 weeks, is where we actually manipulate or intervene in some way. So what that means, for example, is we would start out, and it's kind of similar to a cohort study in which we start out with a group of either people who are disease-free, or if we're trying to look at the effectiveness of a treatment, we would start out with people with a particular health outcome that we're interested in. And then we would do some manipulation where we would say, okay, this group If we want to prevent, for example, and I'll use this example throughout the semester or throughout the class because it's the most relevant right now for the vaccination trials for COVID-19. We wanted to determine whether or not the vaccines that had been developed were effective at preventing COVID-19 or SARS-CoV-2 infection. So they started out with a group of people who were not infected with SARS-CoV-2 and who had never been infected with SARS-CoV-2 ideally. That is a little difficult to fully determine. And then they put one group to receive the vaccine, another group to receive some kind of placebo. So that is our manipulation, where they're providing some drug or some vaccination to one group, and then placebo, a water shot or whatever it is, to another group, and following them forward for a period of months to say who gets infected with COVID-19. And then they examine that data and say, all right, did the group who received the actual vaccine, were they less likely to get infected with COVID-19 than the group who received the placebo shot? So we manipulated, or we provided some kind of preventative measure by form of vaccine to see if it was effective at preventing COVID-19 infection. And we can do that not only for something like a vaccination, but we can also do that for, say, we want to prevent type 2 diabetes. So we can say, all right, if we do a physical activity and we do a diet intervention where we have people eat healthier foods and we have them engage in a certain level of physical activity, is that more effective at preventing future development of type 2 diabetes than just having people be physically active or than just having people eat a healthy diet? So is that combo of the two more effective? So we can randomize people into either receiving a physical activity plus diet intervention, or just a diet intervention, or just a physical activity intervention, or nothing, to see what is the most effective at preventing future development of type 2 diabetes. So in those cases, again, we're manipulating the behavior of the people who are participating in our study to see how that manipulation affects their future health outcomes, or prevents future disease, or is able to treat current disease that they have compared to standard treatment or placebo. So this allows us to better assess how what we're interested in is either preventing future disease or is treating current disease. So experimental research is really the gold standard at understanding disease causality and disease prevention, and how what we're doing works or does not work. And if it doesn't work, then we need to go back to the drawing board to develop something new. So there's some important things about experimental studies that are important for understanding how we can interpret results from them and what they mean and why they are the gold standard for research studies in any field, really, to understand the health of the population. What we're typically talking about is there's two different types of experimental studies. There's a within group design and there's a between group design. A within group design of experimental studies is probably what many of you have heard of before, like a pre-post test. So that could be something like you want to see whether or not caffeine improves a person's running performance. So you have them run a 100-meter dash, you then give them caffeine, you have them run a 100-meter dash again, and you see whether or not their running performance improved after you gave them that supplement. And that is evaluating it on that same person. They serve as their own control. The strengths of that are that, you're able to see within that individual, how does their performance change after giving that intervention? But the weakness of that is that you're not able to assess what we call confounding or other things that could impact their performance outside of those individual level behaviors. So typically when we're doing experimental research, what we want to do is what we call a comparison or a between group design. And this is our typical design for things like randomized controlled trials, where you recruit a group of people to participate in your study. One group receives the intervention, one group does not receive the intervention, and then you look at from before they received the intervention to after. Did the group who received the intervention have a better outcome than the group who did not receive the intervention? And that tells you whether or not that manipulation or that intervention was effective at changing that outcome that you were trying to change, whether that is treating disease, preventing development of disease, or whatever it is that you're interested in doing. And so that's where the clinical trial paradigm fits. When we're looking at randomized clinical trials, we start out with a group of people who we recruit to participate in our research study. And where the randomized part comes in is that once we have recruited a group of people to participate in our study, they go through this process that we call randomization, where every person who we recruited to participate in this study, so say I'm doing a study and I recruit the 24 of you who are here in this class today, you are all have agreed to participate and said, yes, I want to be part of this research study. Then what I would do is I'd say, all right, based on you agreeing to participate in the study, you may receive the intervention, you may receive the control and some placebo where you're not actually receiving the drug or the intervention that I'm trying to test to see if it's effective. But that decision about what you're going to receive, either the intervention or the control, is left up to chance. So I would then throw all of your names, and there's actually a lot of different ways to randomize people, and I'm not going to go through all of those different ways that you can randomize. But one way I could do it is I could throw all of your names into a random number generator, and it would give you each a number 1 or 2, and 1 could indicate intervention, 2 can indicate control. Have nothing to do with that process, but a computer is just randomly saying, all right, Sarah, you're going to get intervention. Mike, you're going to get control. Jasmine, you're going to get intervention. Karina, you're going to get intervention. Cassidy, you're going to get control. So now that process of assigning people to intervention or control is completely random and out of the hands of the actual researcher who is conducting the research study. Why might you think this process of randomization is important when we're conducting an experimental research study? So why do we go through that process of randomization? Any ideas?
To remove some sort of bias.
What might that bias be that we want to remove?
Could it be like a researcher's bias on subjects? Like you might not think you're selecting people on purpose, but through like social influence and culture, you might be selecting one type of subject over another to select either an intervention or the control.
Good. So let's say that I am doing a COVID-19 vaccine trial. I recruit a group of people and I need to assign them to either receiving the vaccine or receiving some placebo shot. So now I, as a researcher, I'm like, I really want my vaccine to be effective and I really want to make sure that it's showing that it works. So I want to really show that it works at preventing hospitalization and preventing mortality. So as I recruit people, I assign everyone who's under 40 to the intervention group and everyone who's over 40 to my control group. So how would that affect the results if I'm assigning all younger people to receive the vaccine and all older people to receive the control? What would you expect the results to be if we were wanting to prevent hospitalization and mortality from COVID-19? It'd probably show that it's really good at preventing hospitalization and mortality from COVID-19. Why? Because we know that younger people are less likely to be hospitalized and or die from COVID-19 than older people are. So based on that data, if we say we're only going to assign young people to the intervention, that's going to result in a bias in the results because our intervention group does not have the same risk for hospitalization or mortality as our control group. So that's what this randomization process tries to do, where now when we do randomization, everyone who we recruited, whether or not they're old or young, they have an equal chance of being in an intervention or a control. And ideally, because we know that age is a risk factor for hospitalization and mortality from COVID-19, We want to ensure that we have an equal number of both old and young people in our intervention group as we do in our control group. So what this process of randomization does and why it's so important is it tries to ensure that our control group and our intervention group are as similar as possible to each other by all potential characteristics that could affect the results of our research study, or could affect the effectiveness of the vaccine or the effectiveness of the treatment. So another example might be, say you have a new drug to treat a cancer, and you recruit people with a particular cancer, and you're going to see if this new drug compared to standard treatment is effective at treating that cancer. Well, if you assign all cases of stage 1 and stage 2 cancer to the intervention group and all cases of stage 3 or 4 cancer to the control group, obviously that drug is going to look like it's more effective than that standard treatment, because the people who are being treated by it have a less severe case of that cancer than the people who are not. So that's what this randomization process is trying to do, is ensure that that bias that we could, as researchers, potentially put into the studies in the way that we're putting people in the intervention or control, or a number of other things, is taken into account. What's also important about this randomization process is, as we've talked about, so say we're trying to prevent type 2 diabetes. We know that there are a number of things that can lead to a lower risk of type 2 diabetes. But we also know that there are multiple potential factors that can lead to most chronic diseases. And there may still be things that we don't know about because we haven't been able to examine them, either physiologically, biologically, genetic factors, environmental factors, that could increase a person's risk for a particular health outcome. So what the randomization process also hopes to do is, if there are unknown potential things that could increase a person's risk for the disease, that those hidden factors would have an equal distribution in the intervention group and the control group. And those are things we don't know that we have to control for, or we don't know that we have to take into account, because we unfortunately haven't been able to determine all of the causes of potential disease or potential adverse health outcomes. And so that's what randomization does, by making our control group and our intervention group look as similar as possible, where everyone has an equal opportunity to participate in either one. And it also ensures that there's no bias by the researcher or the physician who's treating people in the way that they treat those patients. So for example, if I'm a physician and I know that my patient has received some new experimental drug, I might also provide different care to them to ensure that that experimental drug is effective. Providing different care to people who have received that new experimental drug than I'm providing to my control group who hasn't received that drug would bias the results of the study and would lead to us finding something different if that wasn't done. And so that is an important part of this process. The other alternative to random assignment is not randomly assigning, and then people just being put into groups because they're just putting in, I'm just going to say, all right, Madison, you're in group 1, Karina, you're in group 2, and I'm not going to actually take into account randomization at all. This is done in many cases, typically due to limited funding, for ethical reasons. So for example, we can't randomly assign people to smoke or not smoke because we know smoking is a risk factor for many diseases, including lung cancer. So we can't say, I'm going to do a clinical study to say, does smoking lead to lung cancer, because we already have good evidence about that. Or if there's something where the entire population is affected by some disease, it might be hard to randomize people because the entire population is affected. That's super rare though. So randomization has a lot of advantages. It helps eliminate both conscious and unconscious bias in selection of participants and their putting into the intervention to control. It averages out those potential differences between groups, and make sure that our people who are receiving the intervention are as similar as possible to people who are not. Some disadvantages are that there could be ethical issues with randomization, as I've mentioned, and it could interfere with the doctor-patient relationship, or it could interfere with the doctor-researcher relationship, where if a doctor doesn't actually know what drug their patient is receiving, that might make the recommendations and the care that they're providing a little bit more difficult. But that's why we also, when participants are going to select to participate in a research study, it's made very clear, we may not know what drug you're receiving. We're going to provide the best treatment that we can based on a standard level of care that everyone receives, but we don't know the full extent of what treatment you may be receiving because of this research process that we're going through. And anyone who decides to participate in research has to make that decision of whether or not they're willing to take that chance of participating in this experimental study where we're not fully aware of whether or not what they're receiving is effective and will work for their particular disease that they're trying to treat or prevent whatever it is that they're trying to prevent. Another process that we go through in experimental studies is what we call blinding. So along with randomization, blinding is an important part of understanding disease causality. And what blinding in a randomized clinical trial means is that the subjects themselves don't know whether or not they're in the study or the control group. So for example, everyone who participated in the COVID-19 vaccine trial, they did not know whether or not they received some placebo or whether or not they received the actual vaccine. They were blinded to that. And there's different levels of blinding for the participants, for the people who are administering, the researchers and the physicians, and also for the people who are analyzing the data, which we'll talk about in a second. The purpose of blinding people to whether or not they received the vaccine or the placebo or the control is that, one, there's this placebo effect that we've been able to see in research, that just by someone being told you've received this drug that's supposed to prevent this disease or help treat this disease or whatever it is, that they might actually get better even if they didn't actually receive that drug. So that's what we call the placebo effect, where people's condition may improve just basically because they thought they received something that's supposed to help their condition. And so we want to be able to prevent that improvement just because they think that they're supposed to improve. The other thing that might happen too is if we're thinking about the vaccination trial, if someone knows that they received the vaccine, they may be more likely to, say, go out and interact with friends or go do things. Whereas someone who receives the placebo may be like, oh, I didn't receive the placebo, so I'm still not going to go out and hang out with people, or I'm not going to go do these things. So based on whether or not they received the placebo or the vaccine, they may change their behaviors. Those changes in behaviors change their risk for disease, and then in turn will affect the results of the study. So that blinding process ensures that especially the participants in the research study aren't changing things or aren't having some perceived benefit of what it is that we're doing only because they think it's supposed to help them. And there's multiple levels of blinding, and there's 3 different levels. In a single blinded study, the participant doesn't know whether they received the intervention or the control, but the physician or the researcher knows who received the intervention or the control. In a double-blind study, which is typically what's most commonly done, neither the participant nor the investigator, the physician that's treating them, or the researcher knows whether or not the participant received the intervention or the control. Rather, there's some third party who is overseeing who receives the intervention or control. And so that makes sure that the physician or the researcher is not treating the person who received the intervention differently than they would someone who didn't receive the intervention. And then there's also a third step of blinding. In a triple blind study, which are becoming more and more common, the participant doesn't know that whether they received the intervention or the control. The researcher and the physician don't know whether or not they received the intervention and control. And then importantly, the statistician, the person who's working with the data to determine whether or not there was an improvement or a benefit to that intervention compared to control, doesn't know who was in the intervention, who was in the control. So rather what they would receive is they would say, this group A, this is group B, or this is group X, this is group Y. They don't know if group X is the intervention of the control. They don't know if group Y is the intervention of the control. They just do the statistical analysis and say, these are results that we found. Once they have the results of that study, then they would unblind those results and say, all right, group A was control, group B was intervention. That becomes important because there are ways that data can be manipulated to make it look better than it actually is. And so we need transparency in the process of how the data was used to examine the effectiveness of any intervention. And by eliminating or making sure that the statistician doesn't know what they're analyzing and they're just giving us the results, that can make sure that there reduces any chance that they may bias the results by changing how they're doing the analysis. And so these are all parts of the process to ensure that there's a thorough process to conduct the study and to understand the results, so that when we're making some recommendations, such as the vaccination is 94% effective at preventing COVID-19 hospitalization and 100% effective at preventing mortality, then we know that that is not some biased result because there were issues that happened throughout the study. And so these are important steps of determining how treatments work, how vaccinations work, how interventions to prevent disease development work, and so on. And there's multiple phases of clinical trials that all new drugs, all interventions go through to ensure that not only are they effective, but more than that, especially for drug trials and vaccination trials, to ensure that they're safe. So before any vaccination, before any drug is ever given to a human, it first goes through what we call preclinical trials, which are animal and culture-based studies. So they do things in labs, they give the animals the drugs to see how it is that they're responding to those drugs. And we use animal models like mice and rats and so on, because they often respond similarly to humans to different things, but they're not perfect. So an animal model is just the start of understanding, is this effective? Does this drug reduce the tumor size in a mouse or a rat? And if so, can we start to test this out in humans? A phase 1 clinical trial is an unblinded, uncontrolled study where the participants know that they're receiving some experimental drug, and they know that it has only been tested in animals and that we're trying to determine, essentially, is it safe in humans? Because something that is deemed safe in animals may not be safe in humans, and we have to test it to ensure that. So that phase 1 trial is typically really small, less than 30 people, and all we're determining is safety. Is this going to be safe if we give it to a human, or are there going to be a lot of adverse health outcomes as a result of it? Then, once we move and we determine safety at the basic level, we move to a phase 2 trial, which is randomized and it is blinded, but it's still small, usually less than 50 people. And what this is, phase 2 trials are done to determine tolerability. So when we're looking at a drug or a vaccine, how much of the dosage, how much of the actual active ingredients in that vaccine can a person tolerate? And how much do we actually need to prevent disease or to treat disease? So now we're looking at how much of the drug or the vaccine do we need to give? What are the potential side effects of that potential drug or vaccine? And is it safe? And at all levels, we're examining safety of clinical trials. We're always examining safety. But that phase 2 is important for refining what it is that we're going to be giving a larger group of people in a phase 3 trial. And that phase 3 trial is what we're most familiar with, and that is the randomized double-blinded clinical trial. So the phase 3 trial is what we learned most about during this pandemic, where they all started, last August, last September, testing the effectiveness of the different COVID-19 vaccines. And so phase 3 trials, their goal, we've determined safety, we've determined dosage, we've determined the minimal side effects. Now phase 3 is meant to determine efficacy. What efficacy is how good is that vaccine at preventing the outcomes that we're interested in. So COVID-19 infection, COVID-19 hospitalization, COVID-19 mortality. And what that efficacy is, and efficacy is different from effectiveness. Efficacy means in a controlled situation like a clinical trial. So we know who the participants are, we've tested, we know who's in, at some point we will know who's in the control versus who's in the intervention and receiving the vaccine. And we're determining in that controlled situation as part of a research study, does this vaccine do what we want it to do? Does this new drug treatment for cancer do what we want it to do? And then from that efficacy, if we've determined that it's efficacious like we have with the COVID-19 vaccine trials, then when that vaccine is given to the larger population, we can continue to monitor and say, all right, among those who are vaccinated in general, are they having less infection? Are they having less hospitalization and mortality? And that's where we determine its effectiveness in a real world setting. So efficacy is in a research study, effectiveness is in a real world study. And I make that distinction because actually a lot of the way that efficacy was talked about in the media was wrong for the COVID-19 vaccinations because they were conflating efficacy with effectiveness. They're very similar, but a drug's or a vaccine's efficacy may be slightly different than its effectiveness when we're in a real world setting, but ideally they will be very similar to each other. And so once we've determined that that potential vaccine or drug is effective or efficacious in a trial, then that's when it would get approval by the FDA and other accredited bodies that will say that we can actually administer this to the population. So then others can receive it as well. But that doesn't mean that that research process and that understanding that drug stops at that phase 3 trial. There's what we call phase 4 trials as well. And that could be randomized or non-randomized. Typically, they're not randomized. And what a phase 4 trial is, once that drug has been approved, it's being administered to the population, then now we're continuing to monitor side effects. We're continuing to monitor how people are responding to that drug or to that vaccine. We're continuing to monitor how it's working in the population to ensure that it is actually effective when we're in this real world setting. And that process is important for examining the ongoing and long-term safety and effectiveness of the drugs and the interventions and the vaccines that we're using to both treat and prevent disease in our population. And so I'm sure you've all seen that recently the government stopped the administration of the J&J vaccination in the United States as a result of there being 6 people getting blood clots after getting the vaccine. That does not mean that the vaccine is not safe. That does not mean that the vaccine is not effective. What them stopping the administration of the vaccine means is that our systems that are in place, this kind of phase 4 trial level of continuing to examine side effects and safety and benefits of the vaccine are working. And that they're wanting to evaluate that data to say, is this something that we should be worried about that we, for some reason, or that wasn't picked up in the phase 3 clinical trial, but now that over 6 million people have received this vaccine, do we need to worry about this potential for blood clots? And does that potential for blood clots pose a larger risk than the benefit of administering this J&J vaccine to the population? My hunch is, and this is all based on just what I've seen and what I know about why they stopped the trial, is that likely in the next couple of days, they're going to say, we've examined the data and the vaccine is safe and the benefits are overwhelmingly overshadow any risk of potential blood clots from getting the vaccine, because the rate, so the number of people out of the number of people who've gotten the vaccine of blood clots from the vaccine is so low that that's not something that we're going to be worried about for the majority of people. And actually, and you may have seen this too, for example, for women, risk of blood clots from taking birth control is much higher than the risk of blood clots based on our current data from the J&J vaccine. And so we have to evaluate all of that data. And just saying that we're going to do a vaccine, that we're going to use a new treatment, that doesn't mean that there aren't potential side effects. That doesn't mean that there's potential adverse outcomes. But what that does mean is that the benefits of that drug, the benefits of that vaccine far outweigh the potential adverse outcomes from that. And that means that if we administer this to the large group of the population, that we're going to see an overall benefit as a whole that overshadows any potential risk that we might see from using that vaccine or using that drug. And that is why that phase 4 part of this is so important, and why them stopping the J&J vaccine administration actually just shows that our system is functioning properly and that all of those checks and balances are in place to ensure the ongoing safety and effectiveness of any drug or vaccine that we are administering in our population. And there have been times in the past where drugs have been pulled from the market because after ongoing testing, they found that there were long-term side effects that outweighed the benefits of using that particular drug. And that again, just shows that this process is continuing to work, and that is an important part of the phases of clinical trials. So challenges with clinical trials, and as you can imagine, they're costly, they take a lot of time, they cost a lot of money. They may not be suitable for ethical reasons. They may not be suitable for rare diseases, and they may not be suitable for blinding. So for example, they blinded participants in the vaccine trials, but sometimes that blinding process doesn't work because, as anyone who's received the vaccine, oftentimes after getting the vaccine, if you actually received the vaccine, you get a sore arm, you might get body aches or chills or a fever, you might have some kind of symptoms that are a result of receiving that vaccine. That might indicate to a person, even though they weren't told they received the vaccine, if they've gotten these adverse side effects, they might say, well, if I just received a placebo shot, I probably wouldn't get body aches and chills and a fever and so on. So that might indicate to a person that they were actually in the intervention arm versus the control arm. I'll give you another example, actually. So I have participated in clinical trials before, about 10, and I've done a few of them. I just think it's kind of fun, and you can get paid to participate in clinical trials, though getting paid you need to weigh whether or not, the $300 that you might get outweighs the potential adverse effects of participating in it and testing a new drug or vaccine or whatever it is. And that's an individual decision. But I participated in a clinical trial like 10 years ago for acne drug. And so I always had really bad acne growing up. And so I was like 20 years old, and I was like, oh, I've taken a lot of medications for my acne anyway, may as well go and get paid a few $100s to test out this new topical medication. It was a double-blinded study. They gave me, it was just a topical cream that I put on every day. I went in, I think once a month for like 6 months to have my severity of my acne evaluated by a doctor. The doctor didn't know whether or not I had just received some random lotion or if I had received the actual drug that they were testing out. And so it was blinded, but about 2 weeks into the study, I knew that I was actually in the experimental group, and I told the doctor that in my follow-up, and he asked why. And so what they were testing out was a benzoyl peroxide combined with another drug in this medicine. If you've ever used an acne medication, you know that benzoyl peroxide can bleach and stain towels and sheets and other things. So I was using this medication, using towels, and I looked at, and then I had my pillowcase and it was bleached. So I knew fairly quickly, yeah, this has to be the drug because this has benzoyl peroxide in it, and it has bleached out some of my sheets and my towels that I'm using to wash my face. So I told the doctor that, and he was like, "Oh, okay, well that's interesting. No, I don't know for sure. They could have potentially put something in that drug that made it also bleach things out, which they probably wouldn't do." But turned out at the end, when I was unblinded, I was in the intervention group and was able to figure that out because I had so much experience with using probably like 50 different acne medications throughout my life. And so that is an important part of the process, though, that researchers need to take into account. What they try to do, so for example, if there's a drug or a pill that you have to take, what they typically do with the intervention versus the control is they try to make those pills look identical to each other. They try to make those pills taste identical to each other, and those types of things, so that somebody who is in the control, you can't physically tell the difference between that control or that intervention. For the thing like the acne medication that I was testing out, sometimes they can't, right? They can make them smell the same. They can make them have similar principles and stuff. They can have a similar consistency. But what they can't do is they can't make it have this effect of the actual drug, like bleaching a sheet or a towel, because now they're potentially adding in some substance that can also change the control arm that they're doing too. That makes it harder to evaluate. So what they just try to do is make those things as similar as possible. Same thing with the vaccine trials. They can't put something in the placebo that's going to cause a person to get fevers and chills and body aches and all of those types of reactions, because again, that might affect the results of the study as a whole. So they do as best as they can to make those interventions and control conditions look as similar as possible within reason. There have been times where that's been done in unethical ways. So for example, when they've looked at whether getting knee surgery is effective at preventing like pain and further injury and stuff in the past, and these types of studies are not ethical anymore, they've either randomized people to getting the actual surgery that they need, or to getting some sham surgery where they basically poke holes in people. They do a mock surgery, but they don't actually perform the procedure that is needed to treat that disease or to treat that muscle tear or tendon tear or whatever it is, to see if just a person thinking that they received that surgery was just as effective at actually receiving that surgery. And actually there have been cases where they've shown that, for example, fixing a tear in a muscle or a tendon wasn't more effective than actually just doing a sham surgery. As you can imagine, that's highly unethical, well, really questionable in terms of a practice of telling somebody, we're going to put you through anesthesia, we're going to do this surgery that has health risks, not just from the anesthesia, but from the surgery itself. And we're going to see if getting a sham surgery versus getting the actual surgery leads to different health outcomes. So we don't do those types of studies anymore. They've been done in the past, but again, it's very questionable in terms of the ethics and the risk that you're putting people through to receive some kind of sham surgery. So as I've mentioned, randomized controlled trials are the gold standard for determining causality. Randomization is key for reducing bias, and blinding is also key for reducing just potential effects of people knowing that they're part of the process and whether or not they got the drug or not the drug, and it helps mask the placebo effect. There are some issues with generalizability of results from experimental studies. I think I'd mentioned this in the past. When we look at who participates in clinical trials, typically about 90% of participants in clinical trials are white, about 70% are males. And so that means that the participants in clinical trials don't reflect the demographic makeup of our population as a whole. So that means that we actually haven't tested a lot of drugs in the population as a whole, or the effectiveness of things in the population as a whole. And it's potential that there may be specific genetic or other differences between groups of people that could lead to those particular treatments or those drugs or those vaccines being less effective or have a different effectiveness or safety in different groups if they're never tested. And that's been shown in several studies, actually. So randomized clinical trials and experimental studies in general are really important for determining causality, but there are a lot of limitations to them and we can't always do them. And before we ever get to the point of doing a randomized control trial and experimental study, we always need to do multiple other types of studies first to determine whether or not we need to do a clinical trial. So in summary, we've talked about a lot of different types of research studies: case control, cross-sectional, prospective, and experimental studies, the benefits and the cons to each of them. And this is part of, you could do this as one of your videos as well, for your teachings, of just doing a short 7 or 8 minute summary of what are the different types of studies, what level of evidence do we get from them, and how are they conducted in short. Obviously, I'm giving you all 30 to 45 minute lectures on each of these types of studies. You would give a 1 to 2 minutes on each of these types of studies and kind of sum up why study design is important and understanding the differences between them. And you could do that for your final project. And then lastly for today, just to kind of introduce some things that we'll talk about over the next couple of weeks. When we're talking about disease causality and epidemiology, if our ultimate goal is determining, does this treatment work? Does this vaccine work? Does this intervention work at preventing disease? Or does smoking lead to lung cancer, or whatever it is? What are all the things that can get in the way of examining disease causality? And all of these things under this causal effect, which is our ultimate goal, can affect the results of our research studies, whether that is random error, or we'll talk about next week confounding. We'll talk about next week information bias and selection bias, which are biases in the way that we are selecting people to participate in our studies, and then also biases in the way that we're collecting data from those people. But then there's also other forms of bias, like publication bias, bias in the way we use knowledge, and so on. And so there are a lot of things that can affect the results of our research studies. So one of the things that I want to empower you all to be able to do, and why I teach so much about the different types of studies, and then starting next week about these biases and the threats to research, is I want you all to be able to look at a study and say, did they try to take into account the different biases that might affect the results? Did they do the right type of study to be able to say what they're saying? Were there things that they missed when they were examining this particular health outcome, or this vaccine, or this treatment? And if so, how and why is that important that we understand these things that can affect the research study process, and why we do different types of studies to evaluate disease causality? And so we'll sum up some of that next week and as we move through the rest of the semester. So that's where I'll end actually for this. Are there any questions about experimental studies, any questions about study design in general, or anything that you're just curious about at all at this point? Cool. Well, hearing nothing, we can end class there for today. So as I said, don't forget to complete your homeworks. If you have questions about your homework, you have questions about your final accumulating project, or what you need to do, or anything, please don't hesitate to reach out to me anytime. Make sure that you let me know if you're going to work with another person for your final project. And don't forget to schedule your last office hour if I have not talked to you already. But otherwise, I hope you all have a great rest of your week. Hope you have a great weekend. Do something fun, and let me know if you need anything at all.
Thank you, Professor.
Thank you.
Thank you.
Thanks, Professor.
Bye,
Sounds
Doctor.
Thank you.
interesting.
Bye, everyone.